I'm Dr. Joel Bessmer. I'm the medical director for Strada Healthcare in Omaha, Nebraska. Next to me is my son, Ryan Bessmer, and Ryan runs all of our marketing and sales and those kinds of things. And a couple of things I'm going to touch on in my talk are really his ball game. So I thought rather than me trying to do it and pretend like I know what's going on, I'll let the expert do the presentation. And then Sean is on also for us to follow up with. So I'm going to get us started. If you want to go to the first slide. So Strata Healthcare is a direct primary care company here in Omaha, Nebraska, with affiliates in a number of other states. Strata Healthcare was started back in 2016, and when we put it together, direct primary care was well known, but it was illegal in the state of Nebraska, and is the reason we're kind of late to the game to get started. So in 2016, when we put this together, we put it together specifically to be a solution for employer groups. And the reason we're after employer groups, I think, becomes pretty apparent when you look at this slide. And that is a majority of the purchasers of healthcare in this country are employee groups. It's going to be the employers themselves purchasing it for their employees. And so if you're going to go out and create a business to try and help disrupt, or I love the way Marty put it in his discussions, he doesn't see himself as a disruptor, but maybe a restorer. So if we're going to go back and restore the beauty of our healthcare system, then we want to make sure that this is a group that we can work with and help out. So this next slide is going to talk a little bit about the priorities of the employers in healthcare. And I hope you can see the small print on the side from that standpoint. But the large employer groups for 2021 priorities are more types of virtual services. And I take from that, what they really mean is they want direct primary care. They just don't know that yet. It's going to be important from a standpoint of you going out and marketing your practices and doing these things to understand it may be what they want, but you have to convince them that direct primary care is that answer. They're looking to expand access to medical health care services, which is another thing that's easy for us to do. Focus on strategies that moderate high cost claims, which honestly is what primary care is about. We handle 90% of this. And if we can do a better job in the upfront, we know that there's great data that we can certainly affect those high claim costs down the road. Offer care through centers of excellence for additional conditions. So once again, if the primary care giver gets to be involved in making those decisions, we can then be able to talk to the employees about where is the best place to go get your cabbage, where is the best place to go get your knee replacement, and trying to let those big employer groups know that we are working with centers of excellence, and that you will be working with centers of excellence becomes an important part of that. And then lastly, I really think employees want networks. They want to know that when they've got employees in Omaha and Kansas City and Des Moines and up in Wisconsin and South Dakota and Denver, Colorado, they want to know that they can treat all of their employees the same in a benefit group. So they want to be able to offer direct primary care to all their employees. And from my standpoint, what that means to me is they really want us to figure out how we as direct primary care providers work together. And that's one of the beauties of Strata Healthcare is becoming an affiliate with us. Doesn't cost you any money or anything like that. So we are constantly calling up other direct primary care providers and saying, hey, we've got some patients in your community. We'd love to affiliate with you so that we can start sending you patients. So I hope if you're listening, we're able to call you in the near future.
Okay, I believe this one is mine.
It's yours.
Yeah, so good to see everyone. This is my first time ever talking at a HINT Summit, and I'm going to talk a little bit about how you actually take this knowledge of, I want to work with an employer group, but actually make it happen. And I think to launch this, three things have to be necessary. The first is, as my father mentioned, you need to have at least some type of a network with employer groups. And I'm talking something beyond a really small group. But if a 100, 200 life group is going to deploy direct primary care, they're likely going to want you to have more than one site. And so whether that means you creating your own affiliate network or joining a larger one that's already existing so that you can scale up for this group, having a strong, and I know network's not always the best term to use in direct primary care. Clint Flanagan likes to say community. Having a strong community of direct primary care is necessary. You also need to have a firm marketing plan to be able to reach them. And then we'll talk a little bit about the ability to report and show metrics and data and things. But so on the left, we have marketing, and I always emphasize to have a written marketing plan. Us personally, here's some things that we have found very effective. Direct mail is something that we do in every community that we launch into. And that's working directly with the United States Post Office and sending to certain zip codes of demographics. But honestly, a really great thing that we've done is working with Chamber of Commerce lists and sending a letter out from one of our physicians or affiliate providers just saying, hey, we're offering this service, and if you're interested, here's what we can do. Our return on investment on those letters to Chamber of Commerce is really, really high. And buying those things is cheap, normally just a few $100 for a list. So I'd really encourage you, if you are not a part of your Chamber of Commerce, to join, even just to get that list to be able to market to. Social media, of course, you should all be on social media and marketing. Running LinkedIn ads right now has been a great way for us to attract businesses to our website to learn more about our benefits and to be able to download brochures and things like that. Most of our new employer groups come from referrals, and if you're not asking for referrals, you're not going to get them. And so if you happen to be in front of a business owner that you currently work with, even if you just take care of him or her and their family, ask him or her about other businesses that they may know. Referrals are really strong, especially in our neck of the woods in the Midwest, where everyone seems like they know each other. And finally, broker engagement. And I'm not going to go too much into that because I know Sean's going to touch on working with strategic partners. But I guess from my experience, don't try and teach a bad broker how to do direct primary care. Keep looking for the good ones. And keep preaching the message to employer groups, because you're going to run into a group that's just got a broker that doesn't know what they're talking about. Help them connect with a better broker. We've just found it really hard to go to a broker that disagrees with direct primary care, asks you for really high commissions, or any commissions for that matter, and trying to work with them just doesn't work. So find a strong broker community that you can connect with and maybe pass referrals back and forth. Secondly, your value proposition. So make sure that when you're going and pitching direct primary care, that you're not always using the same message. So for example, if you're working with a small coffee shop, let's say, that's got 10 to 15 employees, they probably don't have any type of health insurance that they're offering. And so you're going to pitch direct primary care simply as a standalone benefit, meaning it's affordable. We're hoping to cover the majority of the healthcare that your employees will need, but you need to have some type of outlet for them, a preferred referral source like Sedera, or another maybe local broker that can help them with their catastrophic insurance. From experience, sometimes that can come back on you if you just pitch direct primary care without emphasizing that they need some type of catastrophic care to wrap around with it. So make sure you have resources for them if you're pitching as a standalone benefit. If this is a bolt-on benefit for a fully insured policy, so if someone has a commercial health insurance policy from a carrier and they're simply latching on direct primary care, I wouldn't go in and lead with cost savings as the main driver, because most of the time that carrier, even if you avoid a lot of claims, is not going to send them back their money. You're pitching direct primary care to them as a value add to their plan. Where we find the most success is pitching it as a pilot. So pitch it as, let's try this out, and maybe in the coming years you can find a way to go level funded or self-funded. And we'll talk about some of the data that we're able to feed them, even when they don't have a self-insured plan. And then finally, when you're integrating with a self-insured plan like us with some of our larger groups, 500 plus employees, that's where you go in with a cost savings message to say, if I can keep your employees out of emergency rooms, away from unnecessary specialist visits, get them healthier so we're avoiding downstream claims, that's where we can truly prove our value, and work with partners like KPI Ninja to do upfront claims analysis as well. That's a big thing that we'll do for groups. So we say, send us a file of your claims. Here's a CSV of the data points that we need. And then we'll even project and say, here's what we think that we can do for you. So working with the self-funded groups is fun. And I think Sean would probably echo this, that the sales cycle is long with these big groups. So you've got to be talking to them for a while. Don't get disheartened. It's a lot of decision makers in there. And then finally, welcome to HR. You need to stress that your clinic is going to be an extension of a company's HR. You're not going to put more burden on them. And so you're going to be in a variety of enrollment meetings. I would make sure, depending on the demographics that you're going after, you consider having your literature in multiple languages to make it easier for HR to communicate the benefit that they're offering. Make sure that you have someone in your office dedicated to account management to keep track of your employer groups, keep touches on them, make sure that they're satisfied. The life cycle, as I mentioned, to bring on a new group is high, or it takes a while. So do whatever you can to keep the groups that you have happy so you don't have to go and replace them. So having a dedicated account manager is good. And finally, just the value of affiliate networks, where if you're able to either create your own or join one, that's going to really ease your burden there. So, and I'll make the next slide quick because I know we are running short on time, but I mentioned data. And so these are some of the data points that we are able to report on. So with Strata, we've partnered up with KPI Ninja, and we've been partners with them for a few years. We're able to track data from all of our providers, various EHR records. If we're able to get claims from a TPA, we can look at those claims and compare them against maybe members that have direct primary care, those that don't. In the state of Nebraska, we're connected to NEHI for all admissions and discharge and transfer data, so we can see any of our patients that have been admitted to hospital systems. Our lab tests are integrated in with our KPI Ninja data set, so we're able to track biometric outcomes over time, which is really cool to see how our members get healthier. Telemedicine utilization is a great way. We use Spruce, and they've been awesome. And then, of course, using Hint for our demographic and enrollment data. So at least for the telemedicine, Hint data, demographic and enrollment, and lab tests, we're able to give that to anybody, and even EHR data. So even if a company's not self-insured, they don't have their claims data, we can still give them data to show your employees are utilizing direct primary care. And although you may not see the payoff coming in fewer claims, hopefully you're seeing the payoff in the fact that your employees are accessing routine care more effectively.
Lastly, I just wanted to touch a little bit on getting the employees themselves engaged as a part of the direct primary care. And so you can see on this slide, there's just a few businesses, and in all honesty, these are all businesses we've worked with just within the past month as a part of their enrollment meetings. And you might understand VNA being visiting nurses, Becker being a blue collar trenching company, and then you've got state of Nebraska, state troopers, and those kinds of things. Your message to those individual groups becomes very different depending upon who you're talking to. And so once again, just understanding the group you're going to be in front of and talking to, and really that you are an extension of that HR office. And then last but not least, from a comment on this, is just regardless of who the group is, one of the most important things you want to get across at the enrollment meeting and once they get started and you're talking to them is that first exam is critical. It's where you get to develop the relationship with them, get them hooked up onto Spruce so they've got communications. So having somebody on your team that's great with communicating at all different levels from the standpoint of motivating them to come in for their first appointment. So just as a tease prior to the end, going into the question and answer session, I want to make sure that we get a little bit of time to talk about some of the considerations that Strata Healthcare is doing in the face of what we've done with COVID, number one, and number two, what we're going to be doing with COVID and influenza as they come around together. So if that's something you're interested in hearing about, we're going to talk more about that also in the question and answer.
So my name's Sean Schantzen. For those of you who don't know me, I'm one of the co-founders of Health Rosetta, and we sort of sit at the intersection of building next generation health plans and the brokers and the employers and the care providers. My co-founder, Dave Chase, who many of you know, spoke earlier in the event, and he wrote one of the seminal white papers on direct primary care for the California Healthcare Foundation back in 2013. So we've known about and been involved with direct primary care for a long time. But today I want to talk a little bit about the plan's perspective and the employer's perspective on these things, because we see a lot of everyone not being able to speak each other's language quite yet and not know enough about each other's worlds. And so we run into operational issues when we try to actually get deals done, when you try to build actual plans, make those plans work, can run into some challenges. And so if you notice right here, our theme or our tagline is we're empowering community-owned health plans. At core, we think what needs to happen with healthcare is that the infrastructure for transactions and risk management and building of the plans, it needs to return back to the communities in which the services are provided. So very similar to the ways that the reasons that many of you got involved with DPC. And so we call what we're doing is we're empowering, enabling, whatever you want to call it, community-owned health plans. And just a really quick background, think of us as three things, because if you ever search Health Rosetta, you'll see a lot of different people with a lot of different voices about what we are, what we do, and everything. So just a bit of a framework. It's an idea, like a framework and taxonomy, like a Wikipedia for purchasing benefits. It's an ecosystem of people that drive adoption, and then we build a platform of technology and services to simplify doing that. We're half nonprofit, half public benefit corporation for the things the IRS won't let us do in the nonprofit. So we really started this as part of a mission to help, in the terms of my co-founder, restore the American dream. And so value-based primary care is like the broad term that we use, because there's different approaches that different employers want to take, including DPC, but it's the center of care no matter what it is. And so in an ideal world, every Health Rosetta plan should have value-based primary care at the center, and ideally some sort of direct primary care. And so, but if you think about a plan, if you think about the little ID card that those members get that represents comfort to them, that's the big first point to remember, is that that card that they get represents comfort. And we may look at it, it's terrible, it's expensive, but at some level, for every single person that has an ID card from their employer, they feel like if the worst should happen, at least I'm taken care of. And that dynamic extends to the HR leaders and everyone else. But that card represents essentially these 9 things. And in a Health Rosetta plan, these 9 things are good. They're these types of things, but even in any sort of health plan, you have these, it represents access to any sort of plan. And the blue parts on this are the more plan administration, the infrastructure, the risk management, the payment stuff, everything like that. And then the purple stuff is the care. And that would be the second point to remember, is that a lot of the broker world, the TPA world, the employer world is focused around this blue area. So it's hard to get mindset shift with them to understand wait a second, if you keep jiggering around with all these blue things, you're essentially trying to change the fact that you have a Pinto by changing how you buy your Geico. It's just not an effective way to reduce costs, improve quality of care. You've got to get your infrastructure in place correct so that you can tackle these things up here. Or the first 2 points. One is this idea of comfort. That's what that card that the member gets and these benefit plans represent to these people. And the second point is that you kind of have to teach them to speak another language. You have to help them understand that you're helping them build not just a different way of buying their Geico, which is what they're used to hearing, but you're actually helping them change the fact that they're driving a Pinto into a Ferrari. And then the third big point is understand the cost dynamics from a plan's perspective. If a plan, even a smaller plan, 5 to 20% of the members are going to drive around 80% of the spend. It's a hyper Pareto distribution, 80-20, whatever you want to call it. And so it's a very, very small number of things overall drive all of their spend. And we see a lot of overly aggressive ROI numbers coming out of DPC sometimes that can cause problems I'll talk about later, and I can jump into more detail in the breakout session if we want to. But that's the thing to understand, is that most of these employers are coming from this idea that a very, very small number of their very, very sick people are where all the cost is in their health plan, and they're not wrong. And so how do you tackle that? How do you say, well, primary care enables you to tackle that 80% of spend with those sick people? And for employers that do worry about cost, which is almost everyone, even if they say they're worried about experience, they're worried about cost, every single one of them. Understand this dynamic so you can speak their language is really important. We think of there's these 3 structures for approaching direct primary care plans: bolt-on, bolt-in, and built around. So bolt-on might be just a fully insured plan or a high deductible plan, and then the members are just paying for it, or it's just this add-on kind of throwaway thing to the plan. Bolt-in is where you start getting into things like the employer starting to pay, but then maybe they make it optional. They're generally self-funded at this point. And I can jump into funding mechanisms in the breakout if anyone wants to understand what these things mean: self-funding, fully insured, level funded, all these terms. But built around is really ideal. I mean, where primary care is the center of the plan, and then everything kind of flows from that. And by center of the plan, I mean center of access to care within the plan. And so we've seen some plan designs where the members have to go through direct primary care to actually access downstream care to ensure that they actually are guided by direct primary care doctors. Or maybe they just incentivize it. They say, if you go to your direct primary care doctor, all your specialist visits are free, or things like that. So built around plans leverage the member communications element, the quality of the primary care, the plan design, the pre-certification process, things like that, to ensure that everything flows through primary care so that you can really be a quarterback for everything that's happening. Since Kat, we were having some technical issues, I'm going to play attorney, even though I'm a recovering attorney. I'm not a DPC attorney. I'm not an ERISA attorney. I was a securities attorney when I practiced, but I threw in this slide real quick while Joel and Ryan were presenting, just to surface a few of these issues. There are complexities in the contracts you have with employers. Like, a lot of times we'll get contracts from DPC providers that just will not work for an employer, just from a flat legality perspective. So make sure you understand you have an attorney that isn't just a provider contracting attorney with like health plans and things, but has experience contracting with employers, because they'll understand ERISA and the other laws that govern employers, to be the ones creating your contracts. Plan documents, these are sort of like the operating agreements of a plan. You might have heard the term SPD, like a summary plan description or something like that. These are the plan documents, and sometimes you need to have specific language in them depending on what your plan's doing on a self-funded plan to be able to do DPC. State laws, as you know, on your end are variable. They're variable for the employers on various issues as well. And like things like, when should they pay you, at the beginning of the month or the end of the month, things like that. And then compliance issues, employers have lots of filings when they're self-funded they have to make. And you all have to be included in some of those. There's what are called 5,500 filings, things like that. And we see a lot of compliance issues where the employer's never done DPC, and the DPC provider doesn't understand how ERISA works, or how the Department of Labor filings work, or how NICRA or all these other things work, and you run into issues. And the Department of Labor is doing an increasingly large number of audits on DPC-centric plans. And then the last thing is understanding ERISA and fiduciary duties. Fiduciary duties are a very specific concept in the law across all sorts of stuff, with your accountants and your financial advisors and attorneys, and within ERISA there's this concept of fiduciary duties. And so trying to get a basic understanding of ERISA and what a fiduciary duty is and what it means, and what employers are under, what requirements they have as fiduciaries of the plans that they create for their members. The other thing is, think about employer objectives. We've only ever identified 6 objectives for employers. There's lots of other sub things, or lots of other things will tell you these are the 6 things they care about, and everything boils up to this, or they're making stuff up. When you look at their actual decision making, it's one or these 6 things, and they can only do 2 to 3. They only tackle 2 to 3 of these things a year. So a lot of times when you're trying to get the timing to align with a client, with a prospect or something like that, try to make sure you understand their objectives really well, so that you end up in one of those 2 to 3 things. Because if they decide that what you're doing isn't part of one of their 2 to 3 things, you're not going to make it in this year, and you lose a whole entire year, because they generally make decisions once a year. And then the biggest analogy I would think about, so that's the kind of the lay of the land, and I'll talk about in the breakout some more details and things, but and I'm going to use the rest of my time real quick to cover the introduction to some of the stakeholders. But now I'm going to talk about the kind of the operationalizing of this. How do you make these things actually happen? Think of a health plan as like a Mr. Potato Head problem. So a status quo plan is like a misshapen Mr. Potato Head. It has everything you need, but it's not really what you want. It costs too much money. It's inconvenient. It's not great quality care. It's all these bad things we all know about. So the way that we look at it is essentially everyone, all these smart people in healthcare are going around saying, well, I'm an expert in hats. I'm an expert in noses. I can build the world's best nose. And then they take that and they build the world's best nose, and they go to put it back on the Mr. Potato Head, and the nose spot is taken up by the hat. So they put the nose part in the hat part, and then you just have a slightly better misshapen Mr. Potato Head, where the ear might not, or the nose might not be misshapen anymore, but the rest of the plan is. And employers really, what they want to do, even if it's hard for them to get there, is they want to build Wonder Woman Mr. Potato Head, and another one wants Superman Mr. Potato Head. And so helping them solve that problem, the Mr. Potato Head problem, will make you a really deeply valued partner. And these 8 categories are the things that we look at of what are the manifestations? What are the symptoms of the Mr. Potato Head problem, to put it in more clinical terms? All of these things have to be solved for every single one of your plans with an employer. And there's other stakeholders. It's a system. It's not just you. And so there's challenges in this, and how you actually do it well. As Joel and Ryan alluded to, and they've learned this through like war stories I'm sure they've told or can tell you, is The brokers matter a lot. The Health Rosetta advisors, or the brokers in the Health Rosetta programs, we screen them really heavily because we don't want to deal with most brokers, and we're on the plan side. And so we call it transparent expert advisory teams. It's sort of like the captain of your ship as a plan sponsor, an employer. If you don't get that right, very little is going to go right from there. And then the next thing is you have your funding mechanism. Like, are you self-funded? Are you fully insured? Like, what's the wrapper? Like, if you think of like a health plan is like a bunch of groceries, the healthcare services in a health plan is a bunch of groceries. The funding mechanism is what type of bag are you putting it in? And is it plastic? Is it paper? And that's what when you hear self-funded, everyone likes to think, oh, the fact that I'm self-funded makes it better. No, the fact that it's self-funded just changes the risk profile and who bears the risk of it. If you have a bag full of rotten fruit, you still have a bag full of rotten fruit. If you change from a paper bag to a plastic bag, it doesn't change that. And so funding mechanism, it matters because it buys the flexibility for the plan sponsor to spend their money the way that they want to spend their money, which would include DPC. And if they don't get that right, it is very hard to do these things effectively. And then the next thing is this plan administration. These are your TPAs, your plan administrators. In addition to becoming friends with brokers, is you get some experience with employers, then become friends with TPAs, get to know them, hence working on some things with this to help make that easier for everyone. But they're the ones that really call the shots on a day in and day out basis. They administer the plan on behalf of the plan sponsor, on behalf of the employer. Understand plan design issues, like how can you help incentivize people through financial and communication and other things within the plan to actually come to direct primary care? How can you help with this individual stewardship? Like you don't necessarily want to be the phone number on their benefits card that they call. Helping understand how the plan works so that when people come to you, you can answer basic questions about benefits and say, oh, you want to do this? Well, this is how it works. You're going to need approval. This is who you call. And that's the sort of stuff that will kind of differentiate to employers because it'll show what their world is. And these three things on the left, these open the door up for everything else. It's really hard for employers to do a really good job with DPC or really with any strategy unless they have the right advisory teams, the right funding mechanism, and the right plan administration structure and partners, because that opens the door for them to be able to customize their plans, spend their money in different ways, create different incentives, contract in unique ways, do all these things we want to do. You can't do those unless these things are all tackled. And they're boring and they're esoteric. And I'm a securities attorney by background, and I still find them boring and esoteric. But they're necessary and they're really critical to being able to have a value-based primary care program within a plan. And then the last thing is just, we see a lot of executional pitfalls. So first is coordinating with other stakeholders. This is a good example of there's case management and medical management in these plans, and there's TPAs, and there's reporting that gets done by the brokers on finance and all these other things. And so developing swim lanes, like we've identified about 136 member needs that need to get solved by a plan. And when we architect plans, we basically map who's in charge of each of those those swim lanes, because these things exist for a reason. Like we all like to, ourselves included, think a lot of like non-clinician based case management and care navigation things is pointless and a waste of money. However, there is another reason why employers do that relates to fiduciary duties, because of issues that I'm not going to describe here, that if you want to ask me in the breakout session, I'll explain what those are. But there are fiduciary reasons why those things exist that have nothing to do with the effectiveness of what they purport to do. And it's really like a risk issue. That'd be the first thing, is coordinating with stakeholders. Swim lanes, understanding why those swim lanes exist, why the other players exist, even if by necessity, is the first one. The second was careful what you call a plan. Like we see a lot of people is like on the DPC side saying, hey, we have a plan. And that's a term of art that has very specific cultural meanings to employers. It also has very specific regulatory meanings within ERISA in particular of what a benefit plan is. And so when you come in, you say, oh, well, I've curated a few downstream like services like specialists and lab and all these things. That's not a plan to an employer. It is some elements of a plan. It is not access to drugs. It is not hospitals. It is not babies. It is not all these other things that come up that to them have to be part of the plan. So just being careful what you call a plan and being specific about that when you work with people. Understanding the flow of money and how it works and how the trust accounts work and the trust accounts work and the reporting that happens. Like a lot of times we'll see DPC gets kind of thrown on, and then they bill the employer directly, but then the TPA bills something differently, and then the employer then has, or the broker has to do a bunch of work just to answer the very basic question of how much money did I spend last month, which I know sounds very basic, but when you've got 5 different people charging you through different channels, just creating an Excel spreadsheet takes half a day for them to pull together. And so understand the flow of money and seeing how you can fit into that, and partnering with TPAs and others where they can process your money through them so it's part of the consolidated bill, so you feel much more deeply built into the plan. There's also some legal issues around this that talk to Kat if you want to deal with that, of the flow of money within plans. Another thing is overly aggressive ROI models. Avoidance of care is can be a landmine if not tackled well. And this is where we mostly see these overly aggressive ROI models. Is there'll be a lot of upfront selling around, well, we can save this, we can do this, and then here's our model, blah, blah, blah. But then maybe certain things don't happen throughout the course of the year, or maybe the benchmarks that you use for saving are actually higher than what the plan sees. Like we'll see like, oh, the average knee surgery is this much, but the plan is like, well, we don't pay that much for knee surgery, we pay this much, and it's less, that's a lower number. And so then that undermines the ROI model, and a year into the plan, as they're considering renewal, you might have painted yourself into a corner because you set expectations that were unmeetable for reasons that have nothing to do with you. And then the last thing is just there's many other issues. I can answer questions, but there's a lot of executional moving pieces to make these things work, and plans are complex because if you think about it, like think of a simple 500 employee group or 200 employee group. They have to every year put forth a plan that covers every single health scenario that would ever come up. So the moment they start tinkering with that at all, it basically is a Pandora's box of, holy crap, there's how many CPT codes, there's how many types of services, there's how many drugs, and they cost how much, and they're contracted through these different ways. What's awesome is that there's tons of cost savings, there's tons of quality improvements and care experience improvements, but it just requires thoughtful execution as well. And one last thing I'll kind of leave with, if you want to come into my session or my breakout, if you have questions about this, is understanding the dynamics of underwriters and the roles that underwriters play in the self-funding market, and why they're so important. And if you're going to order your order of operations of friends on the plan side to be with, is brokers, TPAs, underwriters. If you can understand what they do and why they do what they do and become friends with them, you'll have significantly more success with employers. So thank you for the time.